Thank you, sir. Thank you for that very kind introduction. My basic introduction actually starts with cardiology. I'm a cardiologist by training, so all the designations said not mention cardiology, but I'm a cardiologist. My bread and butter is cardiology. Uh, so Aristotle once said, attributed to him, he said every story should have a beginning, a middle, and an end. Unfortunately, my um, hard disk got corrupted, so I had to rustle up the slides. So now my story will have a beginning, middle, and an end, but not in that order. So let me start off by with my disclosures. I have no industry conflicts of interest to declare, but I do have conflicts with chronic disease vectors, tobacco, unhealthy diet, and physical inactivity. The funding for this study came from Imperial College London, Center for Chronic Disease Control, Servier, France. So let me start off with this thing about hypertension. What do we know about hypertension? I describe it as a disease of three paradoxes. Very easy to detect, obviously, you require just a manometer, but worldwide, diagnostic rates are dismal. It's easy to treat, but treatment rates are disappointing. Just require one or two drugs for people to take, some lifestyle advice, but treatment rates are very, very dismal uh, many parts of the world. There are now several potent drugs that are available, and they're extremely inexpensive or cheap. But even then, the control rates are abysmal. So the question we need to pose is, how do we improve that awareness, detection, and access to care? And how do we improve the control and sustain it on the long term? I think we need to address these two questions very urgently. And for that, I think we need a redesign of the health system, and four things can help. Task shifting and task sharing, where team based approaches can result in better blood pressure control, digital innovations, telemedicine, and innovations in drug therapy. I'm just going to talk only about one aspect today, which is the innovations in drug therapy. So, we all know that raised blood pressure is the biggest contributor to the global burden of disease and global mortality, leading to almost 11 million deaths a year. So, which is something equivalent of 15 to 15% of all the mortality. So we have around 60 million deaths a year, and 11 million are related to hypertension. Just by increasing the percentage of people whose hypertension is under control globally to 50%. Currently, it's around, if you take the global picture, currently it's around 25-30%. But just increasing it to 50% would prevent 76 million deaths between the years 2023. That's the power of managing hypertension, controlling treating patients to targets. In India, we had this elegant publication from Dr. Mohan's group. Anjana was the first author, in which they projected that there are around 316 million adults with hypertension in India and almost an equal number with hypertension. So, a big problem. When we look at care cascade in hypertension, these are data from the world, and this is based on a meta analysis of around 44 countries across the world. And when we look at it, you look at the panel C, which is Southeast Asia, which is largely from India. You can look at the care cascade of all people with hypertension. Only around 60% claim that their blood pressure was measured. Around 30% were diagnosed. Around 20% are treated, and only around 10% are controlled. So it's quite low as compared to, say, European or Eastern Mediterranean countries. Even there, it's not great, but our part of the world, it's the worst. So there used to be something called the rule of halves or thirds or tenths. When we talk about rule of halves, both for hypertension and diabetes, 50% of those who have hypertension or diabetes are aware. 50% of those who are aware are treated. 50% of those who are treated are controlled. This is the standard thinking everywhere. But when we come to India, it can be as low as a third or it can be as low as a tenth, depending on where you're looking at. Urban locations like Delhi or Chennai can have a third of the people. well controlled, but when you go to rural areas, extremely low. So these are data from the nationwide data from the National Non-Communicable Disease Monitoring Survey and the NFHS National Family Health Survey, and you can see it's the control rate is just around 12% in the National Non-Communicable Disease Monitoring Survey, and in the NFHS it's around 8.5%. Pretty abysmal, pretty low. So, what are the reasons for this inadequate control of blood pressure? The first is people say it's ineffective drugs. For very long, we have been giving milder drugs like atenolol, not a great beta blocker, and that has been the standard treatment for several years. People say it's resistant hypertension, but the figure for resistant hypertension across the world is just around 5%. It's most of the time that the patient is not compliant. It's got nothing to do with true resistant hypertension. There's a huge amount of guideline confusion. Different guidelines are advocating different ways of managing hypertension, different starting doses of drugs, different types of drugs, different ways of up titrating the drugs. So there's a lot of confusion. Drug costs, it's been estimated by the Pure study, which is the largest cohort study in the world, which shows that even in a country like India, where the drugs are inexpensive, people cannot afford even that small amount of money to get treated. Because of drug side effects, many of them stop the drugs and they don't. And obviously, there are these social media messages which say that it's very good to have a little bit of high blood pressure. It's in fact protective. And there are lots of big people who actually believe in this and propagate these on the social. There's poor compliance, there's physician inertia. People come to their doctor, we see them, 140 by 95, come after some time. The patient doesn't come and we also forget about it. And are there true ethnic differences? So these are some of the questions that we need to address. So in terms of clinical trials that have happened so far, do we know about enough about hypertension management? What is the first line of therapy? What should be the drugs that we should? How many drugs at initiation? We use one drug. We use two drugs. Should we use one-fourth doses of four drugs? I mean, there's a trial recently which has been conducted. Or should we use three drugs? And which drug should we use? Should we use ACE inhibitors, beta blockers, calcium channel blockers, diuretics? These are all questions that have been asked in the last 10 years or so. But I just want to show one thing. How do we define a South Asian phenotype or an Indian phenotype? A person of Indian origin, many of us in this room, if we measure, will have a low HDL cholesterol. We have high triglycerides. We have a tendency to dysglycemia and metabolic syndrome. We have central adiposity. Our BMIs are usually okay. The average BMI, even in an urban location like Chennai or Delhi, is around 25. It's not pretty bad, even amongst people with diabetes and with several, cardiovascular disease. Not very high. But abdominal obesity is almost to the tune of 60 to 70%. So central adiposity is a problem, and we have limited exercise. Now, for over 30 years, starting from early 1990s till around 2027, the Indian Hypertension Society guidelines advocated beta blockers as the first line of treatment. What does beta blocker do? Lowers HDL, raises triglycerides, it can raise blood sugar and create insulin resistance, it raises body weight, and it typically accentuates the South Asian fever. So, other fact which would be surprising to all of you is that no ethnicity specific hypertension trial, and we actually don't have a trial on what is best treatment for hypertension. And most of our data comes from the population. We actually follow whatever the Western guidelines have said, and we may tinker it a little bit there and advise treatment based on that. And the most important lesson that we have learned from global hypertension trials in the last decade or so is monotherapy, that single dose is usually inadequate therapy. If you are saying that we are going to give one drug to a patient, not more than 20-25% you will be able to control. You really require two drugs and two starting doses, two half doses. So the WHO guideline also, which came in 2021, says that you should start treatment with any combination of a diuretic, which could be a thiazide or a thiazide-like diuretic, an ACE inhibitor or an ARB, and a calcium channel blocker, preferably a long-acting dihydropyridine calcium channel blocker like amlodipine. And this should be ideally as a single pill combination, and this has been added to the WHO essential medicines list. So, keeping this in mind, we initiated a trial called TopSpin, which is a randomized trial comparing three dual therapies for hypertension treatment among Indians. And this was accepted as a late breaking trial in the recent AHA in November 24. So, it's the same background longish background which I presented. So, that is, most current guidelines recommend combinations of two antihypertensive agents as initial therapy, ideally as single dose combinations. And there's no randomized evidence to inform initial combination therapy for hypertension management in patients of South Asian origin, which is actually 25% of the world's population. So our objective was to compare the efficacy of amlodipine plus perindopril, amlodipine plus indapamide, and perindopril plus indapamide in reducing 24-hour ambulatory blood pressure at 6 months in patients with uncontrolled blood pressure. So, in terms of the design, this was an investigator initiated prospective multi-center single blind 3-arm randomized trial. We had 35 centers all across India, and the inclusion criteria was very simple. Patients had to be between the age of 30 to 79 years, and the sitting office blood pressure should have been between 140 to 159 millimeters on one hypertensive agent, or the sitting office systolic blood pressure should have been between 150 to 179 on no treatment. And exclusion criteria was standard exclusion criteria: past current history of coronary artery disease, stroke, heart failure, secondary hypertension, or being pregnant. And the primary outcome for us was a mean reduction in 24-hour ambulatory systolic blood pressure from baseline to 6 months. You might ask, why didn't we look at hard outcomes? We definitely know that treating hypertension will reduce stroke, will reduce deaths, will reduce heart failure, will reduce kidney disease. So most of the guidelines now say if you have to do trials, you have to look at surrogates like ambulatory blood pressure change, and therefore we chose 24-hour ambulatory systolic blood pressure. And secondary outcomes included 24-hour a change in the 24-hour ambulatory diastolic blood pressure, day and night ambulatory systolic and ambulatory diastolic blood pressure, office systolic blood pressure and diastolic blood pressure, BP control and responder rates, lab parameters, and adverse events. So we assessed around 2,125 patients and excluded 144 and randomized 1,981 patients, and they were equally distributed amongst the three groups. But at 6 months, we had around 84% of follow-up, which did not differ amongst the three groups. And there were several reasons why some of these patients did not come for follow-up. And we did a complex statistical analysis using two different types of multiple imputations in all these patients. And in terms of treatment allocation up-titration, following the enrollment at 2 months, we measured their blood pressure, and if their blood pressure was more than 120 millimeters systolic, we up-titrated them to the full doses. A lot of our physicians were very worried that they will get hypotension and have falls and other kinds of problems. But we said that looking at several recent trials, including the sprint trial, we needed to control the blood pressure to below 120. So anything above 120, we up-titrated the doses. And they were continued till 6 months. And the primary analysis comprised of, as I said, change in the ambulatory systolic blood pressure, but we adjusted for several covariates which might influence the blood pressure change. And secondary analysis included complete case and per protocol analysis. And in terms of sample size assumptions, we assumed that there will be a 3 millimeter difference in the ambulatory systolic blood pressure with a standard deviation of 15 millimeters of mercury and 10% loss to follow-up. So this is a typical participant profile, typical of any hypertensive population in India. The mean age was around 50 years. We strived hard to get enough number of women in the study because most of the studies in India usually have lower number of women. I'm pleased to say that we got close to around 42, 43%. We didn't get 50%, but we got close to 50%. The body mass index in this patient was a little higher. Very few were smokers, and as expected, diabetes was quite high, and dyslipidemia was seen in a small proportion of people, and many of them, at least nearly 60% of them, were on one single dose of antihypertensive medication. And there was no baseline difference in terms of the office systolic, diastolic blood pressure or the ambulatory systolic blood pressure. So, in terms of primary outcome, the good news is that irrespective of the treatment given, irrespective of these three combinations, all of them had a good reduction in blood pressure. The ambulatory systolic blood pressure reduced by around 14 millimeters of mercury at 6 months, which is great news, which means that we could actually get people below 130 by 80, which is the current recommendation for controlling blood pressure. And there were no statistically significant difference amongst these three groups. And one of the problems was nearly 17% did not complete ambulatory blood pressure at 6 months due to a variety of reasons. But we did a sensitivity analysis to look at if there were different kinds of population, if there are different problems. So there were no significant differences, which was reassuring. In terms of secondary outcomes, the ambulatory diastolic blood pressure reduced by around 7.5 millimeters of mercury overall. And again, there was no difference amongst the three groups. In terms of office systolic blood pressure, we saw a huge decline of around 30 millimeters of mercury in overall, and there were no differences across these three groups at 6 months. And similarly, the office diastolic blood pressure reduced by around 14 millimeters of mercury without any difference amongst these three groups. In terms of secondary outcomes, in all the three groups, over 40% people achieved a blood pressure of less than 130 by 80 millimeters of mercury, and over 70% of the people achieved a blood pressure of less than 140 by 90. Recall that statement which said that if globally, if you're able to get at least 50% of the population to less than 140 by 90, the number of lives saved will be huge. And given that context, this has got a very important message. In terms of lab parameters, there were several significant but clinically minor differential changes in renal function, potassium levels. Hypokalemia was noted in around 7% of the population, but none of them really required any treatment specific. And uric acid, there were minor differences. In terms of safety events, 51 participants reported drug withdrawal due to usual adverse events associated with the individual drug classes. In terms of subgroup analysis, there were reductions in ambulatory systolic and ambulatory diastolic blood pressure were similar across all three treatment groups, stratified by age, diabetes status, previously diagnosed hypertension at baseline, and gender. So in summary, we have a very important message. This is a neutral trial, but with very exciting, important message that all three dual combinations evaluated produced similar large reductions in ambulatory blood pressure and clinic blood pressure. There were no significant differences of any measures of blood pressure were apparent after 6 months of follow-up amongst the three combinations studied. Similar high rates of blood pressure control, approximately 70% at less than 140 by 90 and 40% at less than 130 millimeters, were achieved by all three combinations. So, to conclude, in keeping with several current guidelines, the topspin trial suggests that the use of any dual combination from amongst ACE inhibitors, a dihydropyridine calcium channel blocker, and a thiazide-like diuretic can be recommended for effective, well tolerated, and safe blood pressure lowering in a broad spectrum of Indian hypertensive patients. So I have to acknowledge several people, the study participants, the caregivers, the trial steering committee, investigators from the recruiting centers, and many of my own staff and the funders. Thank you very much for hearing me out.